let's get started. So thank you everyone for joining us today. And today we have a webinar with Dr. Chris Kellner from the School of Medicine at Mount Sinai. So he published with us a few years back in 2021. And so his paper was focused on minimally invasive endoscopic intracerebral hemorrhage evacuation. So this was a very well-received article here at JoVE, and so Chris is here today to give us any updates on the procedure that have happened in the last few years. So again, thank you everyone for attending, and there'll be a short question and answer session at the end. Okay, so take it away, Chris.
Great, thanks a lot, Ron. And my apologies to everybody who started watching last time we initiated this, and I had some kind of Zoom disconnection. So let's hope that doesn't happen again. All right, going to screen share. And I think that looks like it's now working. Let me get rid of subtitles. Hi, everybody. I'm a cerebrovascular neurosurgeon at Mount Sinai, and my specialty is in treating patients who come in with various forms of acute stroke. And specifically what we're going to be talking about today is intracerebral hemorrhage, which is bleeding in the material of the brain itself. So this is the kind of stroke that occurs when a blood vessel begins spontaneously bleeding, rather than the kind of stroke you hear about more often, which is when a blood vessel gets blocked by a clot. This is when a blood vessel spontaneously bleeds. And we don't have a lot of options to fix that. And this technique that I'm describing is one way that we can potentially remove that blood. And I'm going to give you some updates since the article we published in JoVE a few years ago. So this is, instead of endoscopic evacuation techniques, this is advanced endoscopic evacuation techniques. Here are my conflicts of interest. I'm involved in a lot of research surrounding cerebrovascular neurosurgery and intracerebral hemorrhage evacuation. And Mount Sinai receives grant support for some of those projects, but I don't personally receive any personal compensation for any of that work. Back in 2018, we published this paper here describing the stereotactic intracerebral hemorrhage underwater blood aspiration technique, or the scuba technique. And you'll see why we called it that as I show you some of the videos. Since then, we have described advanced techniques for performing endoscopic ICH evacuation so that you can more effectively get the blood out in cases in which you face some challenges, such as cases in which there's challenging bleeding, or cases in which the blood clot itself is fibrous and won't come out just by aspirating. For those of you who are not neurosurgeons, not all blood is the same. Some blood is pure liquid and it just comes out as if you're aspirating through a straw. But some blood is highly fibrous and has formed a clot that is even sometimes similar in texture to a softball. So there's a lot of variety of physical mechanics that need to happen to get the blood clot out. And a few devices have been developed to help us do that through the endoscope. I'm going to show you the device we use through the endoscope most often. And let me begin by acknowledging my team here at Mount Sinai. And this is representative of the entire team, really. I've chosen one person from each of the kind of groups that we work with here. And there are many other people behind each of these individuals, but this is Dr. Mako, who's a neurosurgeon in cerebrovascular, and then Dr. Pedersen, who's a chairman of neurosurgery, who's really supported this project and this program as we've developed. And then Dr. Turum is a neurologist here, and the neurology team is essential for evaluating these patients and helping to manage them throughout their hospital stay and afterwards. Dr. Jangiach is an ICU attending in neuro ICU, which is where these patients spend a lot of their time in the hospital after the procedure. Dr. Redlener is an emergency medicine physician, and of course the ER, and bringing these patients in and stabilizing them immediately when they arrive. They're always very, very sick when they arrive. The emergency room is an essential piece of the puzzle. And then Dr. David Petrino represents the rehabilitation aspect, where the patients will get their acute care and then they'll go afterwards to rehabilitation for sometimes many months, sometimes years. And so these are only a small representation of all the people involved in taking care of these patients. And so I mentioned these individuals, and just the fact that it really takes an entire institution to help treat patients like this and develop a technique like this. Our facilities are in New York City. This is where Mount Sinai Hospital is, and this is where Mount Sinai West is. And what we've done at Mount Sinai is, if a patient arrives at any of the Mount Sinai hospitals or any of our referring or affiliated hospitals, we transfer that intracerebral hemorrhage patient to Mount Sinai West down here in this corner. And we do that often using some artificial intelligence technology, where the algorithm, in this particular case, we use Viz AI, will identify an ICH anywhere in the Mount Sinai Health System. It will automatically alert me and the team, and it will show us what the volume is of that ICH, and it'll show us a picture and a video for us to scroll through and see exactly where that is and what the anatomy of it is, so we can plan whether or not that patient is eligible for a study or whether that patient's eligible to have the procedure. And no matter where they arrive, we transfer them to Mount Sinai West, where we've created a center for this kind of disease. Back in 2018, we were attempting to describe the procedure. So I'll just take a few minutes and show you what we described in that paper, and then I'll move on to what we've elaborated on in the advanced techniques over the last few years. So just to recap, the scuba technique includes 2 phases. In the first phase, an endoscope is stereotactically placed into the hematoma, and then irrigation is initiated at a very low level, and aspiration is initiated at a very high level. So there's a high aspiration force at that early stage when there's a lot of hematoma present, and hematoma is aspirated at that single level. And then when that whole level that depth has been aspirated and you see the brain closing in, you'll pull the endoscope back a centimeter or so and repeat the process at that next more shallow depth. Once you've gone to the back of the cavity, you've debulked the intracerebral hemorrhage significantly, you'll increase the irrigation and really wash out the cavity as much as possible, and also improve your visibility. As the blood is washed out, the fluid becomes more clear. You're able to see if any residual clot is there or if there's anything bleeding. And if there is, then you can switch out your instrument to an electrocautery. This specifically is a bipolar cautery, and then you can cauterize that bleeding vessel. I'll show you some videos of that. So here's a cartoon of what that looks like from the side here. You've got the sheath going in, then you've got the endoscope going in through the sheath, then you've got the aspiration wand. In this particular case, this is the Artemis wand by Penumbra going down the endoscope here. Let me start by a case that was one of our early cases, and this case is published in that initial publication, the scuba publication in JNIS in 2018. So this is a 86-year-old gentleman who had a sudden onset of left-sided weakness and lethargy while he was at home eating dinner with his family. And he was brought into one of our satellite hospitals and found to have this approximately, if I remember correctly, 80 cc hemorrhage in the right parieto-temporal areas. Here's the temporal lobe. Here's the parietal lobe up here. And so this is extending from the parietal temporal lobe. Since this time, I've had many clots that look exactly like this in this particular configuration. And I find that it's a very effective technique to approach from a prone position with a burr hole in the superior parietal area, of course, avoiding going anywhere near the motor or sensory areas, more anterior. And by going along this route, I'm able to pretty much get most of the clot most of the time using that strategy. We have a particular score in intracerebral hemorrhage patient management called the ICH score. And depending on some of the clinical characteristics and radiographic characteristics of the patient, it gives us a prognosis of chance of passing away by 30 days. And so this gentleman, because of his age, the size of the blood clot, a small amount of blood in the ventricle, this gentleman had, and the way he presented, he had an ICH score of 4, which is a 97% chance of death at 30 days. We did a few other scans to try to understand what might have caused this hemorrhage. And then we brought him to the operating room for an evacuation. And in this particular case, the evacuation was done between 24 and 48 hours after he had bled. At that time, we were not trying to do them as early as possible. And here is the stereotactic navigation demonstrating how to get to the location that you choose as a target. So in this particular case, here's the target that we've identified in the blood clot. That's where we want our sheath to end up. And here's where we're going to make the burr hole. And so in the operating room, while looking at the patient's head, we're able to use our instruments and see where those are on the stereotactic navigation technology. This is a different patient, but this just shows you what the room setup looks like. Here is the operator. This is me here. Here's my assistant on the left. And here's the patient. The patient's head is here, and the patient's body is on the operating table this way. And you can see in my left hand, I've got the endoscope, and my assistant is holding the sheath. And this is inside the blood clot. And here's the aspiration wand in my right hand. And I'm looking here at the endoscope screen, and you can see that now I've just initiated the procedure, and I'm seeing a lot of blood on the screen as I begin to wash it out and aspirate it. Here's what the video looks like in the initial phase. You can see the aspiration wand at the top here, and you can see some blood clot here that I'm washing and about to engage with. And that's what that looks like right when you begin aspirating. So this is phase 1A. And now we're going to move to phase 1B. You see here some brain has now started to close in, and I'm going to redirect the sheath so that I can see entirely blood again. And if I then aspirate, I'll see entirely blood within the field of the sheath. And so you'll have to do that a few times in the procedure as the brain begins to close down as you decompress the hematoma. Now in phase 2, we're able to see that some space has been created. There might be a little bit of residual blood clot, as you can see here. And now I'll take the aspiration wand and I'll go grab that blood clot or aspirate up that blood clot. The suction strength is very low at this point, just the minimal suction required to aspirate or grab that blood clot. Here's another example of that. Some residual blood clot here. Get right up to it, do a very light aspiration. You can see that cleans that up pretty nicely without disturbing the walls of the cavity. And then occasionally you'll encounter a bleeding vessel. And here's a blood vessel here bleeding. This was the cause of the bleeding in this particular case. And I've got the cautery coming down here, and you can see that I've cauterized it. It's no longer bleeding there. And so that's how bleeding is addressed in general. We use ultrasound, which is what this set of top images looks like. This is pre-evacuation images on the top, or the first two. There's a post-evacuation image here, another post-evacuation image here, and then we've got post-evacuation Dyna CT, which is an intraoperative CT. And what you can see on this is a little bit of air here, but you can also see that the blood clot has been evacuated almost completely here. There's no residual blood seen where that blood clot was. Same here. Here's a coronal view. Here's a post-op day 1 CT. You can see the preoperative blood clot here, and you can see the brain has really closed down, and the residual cavity is very small compared to the volume of the original hematoma. And this is possible because the brain itself is not bloody, but a blood clot has formed and has shouldered its way and pushed brain away from it. So it's possible to get into the blood clot, wash it and aspirate it, and then allow the brain to close down as much to its original configuration as possible. Here's a sagittal view or a side view. Here's a hematoma here on the preoperative scan. And here's the cavity on the postoperative scan. Patients will always ask, what's going to happen to that cavity over time? And it varies by patient, actually. Sometimes the cavity doesn't change. Sometimes it gets smaller over time. We're trying to figure out what predicts what's going to happen to the cavity. But it's not really important, actually. What is most important is that the patient continue to engage in rehab and strengthens the surviving area around the cavity. It's not really about that. Some damage happens initially, and there's no way to avoid that. But by removing the blood, theoretically, you can decompress the brain that's been moved away and decrease the chance of that brain dying, basically, and increase the chance of that brain being recovered. Here's how the patient did in his hospital stay. This is the NIH stroke scale, where a higher number is worse. So the patient came in with a 17 on the stroke scale, and then after getting extubated on post-procedure day 1, was doing a little bit better. and we were seeing a stroke scale of 11. And then throughout the patient's hospital stay, he made steady improvement until he left to go to rehab with a stroke scale of 4, which is only a few minor deficits. At 30 days, his family texted me this video of him in rehab. He was a professional piano player, so he was playing for his rehab physical therapists. And then he went home shortly after that 30-day video. And here he is coming back to my office for follow-up.
In which you are the star and the director, but you're not the writer.
He was doing pretty well at that time. Not passed away, as the prognosis score might have suggested he would be, but he was at home living independently, independent in his ADLs with his family. Since that time, we have come across many patients who have had more challenging blood clots to remove than that video I showed you right there. In cases in which the blood clot is much more fibrous and or the bleeding is more challenging to stop. And so I'm going to show you ways to address those harder cases. And here's what we were describing. We tried to describe some operative tenets to maximize the chance of getting most of the blood clot out every time. And so let me just mention a few of those. The most important one, of course, is to avoid causing any more injury than the patient already has. And that, is the Hippocratic Oath. And that is the main goal of the procedure. You want to make sure you don't cause any new problems, of course. And so there are some areas of the brain that are identified as no-fly zones, essentially, for a surgeon. And here are some of them outlined here. And so when you're planning your approach, the gentleman I just mentioned, we did a superior parietal approach. So that's right through here. That's through a non-eloquent brain region. A lot of approaches are through the frontal lobe, and that works well for blood clots that are egg-shaped in this area right here. We come from the frontal area through the frontal lobe into the blood clot along the long axis of the blood clot. Then there's the idea of minimizing brain distortion. You're putting an endoscope into the hematoma, and to look at this area of the hematoma, for example, you have to move the endoscope, and that's going to torque it around this point, and that's going to cause some disturbance of this area here. And so the residents call that the cone of destruction. And you basically want to minimize that cone by choosing a trajectory along the long axis of the blood clot, and by minimizing your movement while you're doing the procedure. Then there's the concept of cavity distortion. As you're introducing an aspiration force and irrigation forces into the cavity, you want to minimize the sucking down and the expansion of the cavity, because that can theoretically cause trauma to the brain around the hematoma and the cavity as you're working. So to do that, I always minimize the suction forces used and almost never expose suction forces to the cavity unless the suction is on a blood clot. If you are in a liquid area or in a saline-filled area and you activate the suction, which can be fairly strong at times, you'll see that the cavity will close down around the suction. When you release it, it will open back up. And you really want to avoid that. I've seen that lead to bleeding a few times, that you then have to address the bleeding. Speaking of bleeding, let's talk about obtaining and maintaining hemostasis. That is the last operative tenet I'm going to mention. And that is the concept of trying to make sure everything you do minimizes the chance of causing bleeding. And if you do cause bleeding, you address it. And at the end of the procedure, you make sure that there's absolutely no bleeding whatsoever. We also feel very strongly that you should perform intraoperative imaging to check the work, make sure you've hit the goal of the procedure, which is to evacuate at least 80% of the blood clot and to leave no more than 15 milliliters of blood clot left at the end of the procedure. To do that, you really need to get an intraoperative CT. And so we perform our cases in the angiography suite, which has this equipment here. So the patient will have to undergo the procedure on the table, and then you step out, bring in the equipment, perform a CT, and then if any more work needs to be done, it can be done really without any additional activation energy, because the patient is still on the table, still draped, and no additional work needs to be done to go back and do additional evacuation. So let's We talked about the phase a little bit, and now let's dive into what these advanced techniques are that I was referencing. And we've named a few of them, and I've got some videos and some animations to demonstrate them. So here we go. The first one I'm going to talk about, we've been calling the ADAPT technique. And that comes from another kind of stroke treatment that cerebrovascular neurosurgeons do, where you can aspirate a blood clot that's in a vessel by going right up to the blood clot with a suction device and essentially corking the blood clot on the device and then pulling it out. And so that's what we have been doing also in this type of evacuation. So you take the aspiration wand, put it right on the blood clot. If you aspirate it and morcellate it and it doesn't come up into the aspiration wand because it's not digestible, you can just use the suction force as a grasper essentially and grab and aspirate on so that it sticks on the tip of the aspiration wand and then pull it out through the sheath. But you can see here that you can't pull that wand into the endoscope or it will pop off the end of it essentially, and you'll bring in the wand and then lose suction force. You'll lose your connection to the blood clot. So you need to pull out the endoscope and the wand together without pulling the wand into the endoscope. Here's the reference paper for the initial experience with the ADAPT technique in stroke thrombectomy, which is where the name came from. And here's an animation showing how that might work. You can see there the endoscope and the aspiration wand came out together through the sheath, and the sheath doesn't move, it stays in place. Here's what that looks like on a video. You aspirate on the clot and start pulling them both back out. And now you'll see that it's coming out very slowly. Sometimes you'll lose it a little bit and then you have to re-engage it and kind of tease it out through the sheath. Here's another technique called the sheath dissection technique. And this is when you have a highly fibrous clot that appears to be adhered to itself, or you want to differentiate it from the cavity wall so that when you're doing work, you've got the cavity wall protected. And so sometimes using the sheath or using the endoscope and kind of physically pushing the blood clot away from the wall or physically pushing it away from another area of blood clot can be an effective means of dissecting the blood clot to morcellatable or aspiratable pieces. It's essentially a mechanical problem at that point. You can see here the animation demonstrating the sheath and the endoscope kind of manipulating the blood clot itself. Here's a video demonstrating that. Hard to see from the video, but you can see there are clots of different forms here, and I'm using the sheath to gently nudge the clots and to separate the blood clot from other areas that I want the sheath, actually the walls of the sheath, to protect me and the suction force I'm using from the wall of the cavity and maybe even a blood vessel. If I see a blood vessel, I'll get the sheath between the blood vessel and the clot I'm aspirating, or between the wall of the cavity and the clot I'm aspirating, and then go after that clot now that it's within the end of the sheath and the other objects are protected from the suction forces. Then there's another technique called the double ADAPT technique. And sometimes you'll meet a blood clot that is so fibrous and it's not able to be digested to a size that can come up that sheath. And the sheath is 6.3 millimeters in diameter. So there are some blood clots that are larger that cannot be digested below 6.3 millimeters. And in that case, you might have to do a double ADAPT technique, which is where instead of just pulling out the endoscope and the suction wand through the sheath, you're going to pull out everything together. Then you're going to have to put the sheath back in after, but that's okay. You've already got a tract and you've got stereotactic navigation. So in this case, I'll show you this animation here. Here's the aspiration wand. We go back to where it engages the blood clot. Okay. Here is the aspiration wand engaged on the blood clot. The endoscope is all, and the aspiration wand and the endoscope are tip to tip. And then what I do is I hook another aspiration tubing up I turn off the irrigation, hook another aspiration tube up to the port that is often fluid egress. And so now I've got aspiration from the tip of the aspiration wand, and then also aspiration from the tip of the endoscope, separately, 2 aspiration sources now helping to hold on to that blood clot. And because I know that it will get forced off the tip of my devices if I leave the sheath in place, I'll then pull the sheath out as well. And the blood clot can sometimes get caught on the cavity wall here. But if you're gentle about it and take it slowly, you can tease it through most of the time. So here's the animation again. There you go. Here's a video of that being done. It might be hard to see what's going on, but let's see if it's possible. Here's the aspiration one coming down. Here's a big, large fibrous blood clot in the tip of the sheath. And now everything's going to come out together. So from the perspective of the endoscope, you're probably not going to see anything change. But now you've got the sheath. You could just see it for a second there. The sheath endoscope out of the head there. And then finally, the last advanced technique I'm going to talk about is the sheath hover technique. This is a technique I learned from my colleague Tomoyoshi Shigematsu, who is a Japanese neurosurgeon. And he said this is a very common endoscopic technique in his practice, in Japan prior to coming to Mount Sinai. And you essentially direct irrigation onto a bleeding vessel by getting the sheath right up next to it, so that any fluid coming out of the endoscope is going to be directed by the endoscope and the sheath right onto that blood vessel. And so then even a blood vessel that is bleeding actively and robustly, the irrigation fluid can wash that away so that you can see the blood vessel enough to get a cautery device onto it. If it's bleeding and you can't see it, then you can't get the cautery onto it. You really need to be able to see it. So you need to irrigate the fluid away fast enough and strong enough to get visibility enough for it. And the sheath hover technique can help do that. Here's an animation. And there you go. And let me move on to a video. See if we can identify that. Here's a bleeding vessel down here. And so I've got you can see there that I've got the sheath close to that bleeding vessel, and I've got the cautery coming in here. I'm directing the irrigation as much as I can onto that bleeding vessel. Kind of challenging to see there. Sorry about that. All right. And then I'm going to show two cases to demonstrate these techniques. Here is a case of a 47-year-old gentleman who was in the bathroom preparing for his day when he suddenly had onset of left-sided weakness, came into the emergency room and had this fairly small 15 milliliter right frontal blood clot. And, the motor strip is here. And so the blood clot is anterior to the motor strip and pressing on it. So it's in the supplementary motor area, pressing backward. And the gentleman had complete paralysis of his left side, of his left leg and left arm. But he was still able to communicate, and we were able to discuss the potential for this procedure. And there were some benefits, and we decided to move forward with the evacuation to decompress that motor strip and maximize the chance of him getting a good recovery in his strength. And so here are a few videos. I do have some audio from the video, so maybe I will permit that to play. And these are from the advanced scuba paper. So here we go.
Hollow device's suction strength is set to maximum and irrigation is set to low. Liquid and solid clot are aspirated while keeping the tip of the Apollo device within the sheath to minimize cavity distorting forces.
So here we're using low irrigation and high suction
At the
strength.
beginning of the procedure, once a sufficient amount of clot has been aspirated at a particular depth, the sheath is repositioned laterally to explore other parts of the cavity.
So you can see there. Oh, sorry, that advanced. So you can see here, I've got some space here, and here is the cavity wall and some residual blood clot, and I'm exploring laterally, and then I'm going to gently aspirate this residual blood clot here. And that happens at the end of this video here. So let me get to that right there. See that aspiration occurring there. And now I've got the clot cavity completely empty, and I'm going to explore it. Maybe I'll mute so the audio doesn't come up there. So there you can see I'm exploring the cavity and making sure that it's completely clean. and there's nothing aspiratable, nothing bleeding whatsoever, and no residual
At
blood
the
clot. Here's a second case, and that gentleman had rapid improvement in his left arm and leg, and he was able to leave the hospital in only a few days and go to rehab, where he spent a short period of time before getting back to work. And here's a second case I'm going to show you, also in that same paper, and this is a left thalamic and cortical blood clot. So it initiated down here and then bled more superficially. And this patient was approximately a 55-year-old woman who had sudden onset of right-sided weakness. And here are the preoperative photos on the top and the post-evacuation images on the bottom. Here, to make a trajectory along the long axis of the blood clot, you can see that was the trajectory I chose, which in this case involved the patient supine with her head turned, so that when I was approaching, I would be approaching perpendicular to the floor, so that fluid would be able to build up and I'd be able to work in a fluid medium. If you're working horizontally, then there is an air fluid level that gets in the way of the procedure. And so when possible, the scope should always be pointed directly down to the floor to minimize the chance of engaging with that and causing bubbles and engaging with that air fluid level. So here are a few the phases of that case shown, and I'll let the video play here.
At the start of the procedure, the Apollo device's aspiration strength is set to maximum and irrigation is set to low. Liquid and solid clot are suctioned. It is important to keep the tip of the Apollo device within the sheath to minimize cavity distorting forces.
There you go. You can see the blood clot there. Some suction being deployed there.
At the start,
and then the debulking occurs, and after debulking, you're able to now see some space. You're able to see the back of the cavity a little bit.
once a sufficient amount of clot has been aspirated at a particular depth, the other parts of the cavity at that depth are laterally explored by repositioning the sheath. The additional clot is then aspirated.
You can see that at the beginning of that, I had some space there, and then I angled the sheath to the side, and some new clot.
Once a sufficient amount of clot.
Some new clot came into view here, right there, and I was able to put the aspiration wand directly on that and aspirate that. All right, now here I've got most of the blood clot aspirated.
Using the ADAP technique, a tenacious piece of clot is suctioned onto the tip of the Apollo device. The suction strength is increased to maximum, and the endoscope and Apollo are withdrawn with the clot attached.
Of all the aspiration, of all the advanced techniques I was describing, this one is probably the one I use the most often. And you can see here, some pieces are just too large and fibrous to come up into the aspiration wand. And then you use it as a grasper, essentially, where you're gently aspirating without collapsing the cavity, with the minimal suction force necessary to hold on to that blood clot. And you can bring it up into the sheath, and you see that right there. It's essentially being used as a forceps.
As the last step, the cavity is thoroughly assessed for maximum evacuation, residual clot, and bleeding vessels. This step is important to ensure hemostasis to prevent post-operative rebleeding.
Okay. And so we have published our first 100 patients, our experience using endoscopic evacuation with the techniques I've described here. This paper was published in JNIS in 2020. And to give you a few details, this expands upon the scuba paper of 47 patients that we published in 2018, and also those details were presented in a prior JoVE video. Some important things to look at here: the evacuation percentage they were able to achieve in those 100 patients was 88.2%, which is higher than the goal of achieving, at least in our we described a goal of 80%, but the MISTY 3 study showed that it seems like 70% seems like the point at which patients begin to do better, at least with that technique, than patients who are medically managed. But we do know that leaving no more than 15 milliliters is the goal. And so our post-op volume on average was 6 milliliters. So we were able to achieve that goal of leaving no more than 15 milliliters at least 86% of the time. So we felt that this technique that we developed was effective most of the time at getting most of the blood out. Here's some of the details about how long patients would stay with us. The average the NSICU length of stay was 8.5 days, and the average hospital length of stay was 17 days. The mortality at 30 days was 9%, and the patients who appeared to have a good outcome or a modified Rankin score of 0 to 3 at half a year or 180 days was 46%. One problem with these procedures is having rebleeding occur after the procedure, where it seems like things were quiescent in the cavity at the end of the procedure, but then bleeding occurred at some point within 72 hours would be early rebleeding, or at some point within 30 days would be late rebleeding. We only had early rebleeding in 4 patients. None of those patients had symptomatic rebleeding. They did not have any change in their NIH stroke scale. We noticed there was more blood on the post-op day 1 scan than there was on the intraoperative scan. And so that is 4 patients with asymptomatic rebleeding. And then 1 patient on day 30 was in rehabilitation doing well, got worse in rehabilitation, came back and had new bleeding in the cavity. And so that was 1 patient with symptomatic rebleeding at 30 days. We've also discovered in the interim a few other features about endoscopic evacuation and ways in which we think the data supports helping patients get better. And when we looked at features that correlated to patients having a good outcome at 6 months in our data set of 90 patients who had been evacuated within 72 hours, these were the features that we saw. We saw patients who were older did worse, and that's well-known factor. And then patients who had IVH present also did worse. Patients who had a deep hemorrhage did worse, and patients who had a lobar hemorrhage did better. These are well-known factors to predict outcome in ICH. But then we were surprised to see that patients who were evacuated earlier in our 90-patient data set also did better. And it seemed that each hour earlier correlated with a 5% increased chance of a good outcome at 6 months. And so with this information, we have now tried to do the operation as early as possible when patients present to the hospital healthcare system. Here's what that looks like graphed out. Here's the predicted probability of modified Rankin score 0 to 3, which is the good modified Rankin score at 6 months. And here's the time to evacuation. So here is 0 hours, 15 hours after the patient had the bleed, 30 hours after the patient had the bleed, 45 hours. And so you can see that the probability of having a good outcome, at least in our single center data set, non-randomized, but we weren't at this point making plans around patient features to go early or late. We were just doing the case whenever the next available room occurred. And so the later cases went relative to when the patient first had a bleed, it seemed like the worse patients were doing, or the converse is the earlier we were able to get the patient operation done, the higher their probability of having a good outcome. And so this is a correlation. But this is some interesting data that when combined with other data that previously existed at other centers and in other studies, it seems like removing the blood clot earlier is probably helpful for patients. And with that, I'll show you one last case and then I'll complete the presentation. This is a patient in which we performed an early evacuation. And so I'm going to show this to show how to address robust bleeding and also the value of early evacuation from my perspective. So this is a 55-year-old gentleman who had a right basal ganglia 28 cc or 28 milliliter intracerebral hemorrhage, and his stroke scale at the time of that expansion to 28 milliliters was 15. Here was his original CT, and then shortly after this, he worsened and had a CT that looked like this. And when his hematoma had enlarged to this point, then we made the decision to take him quickly to the operating room. Because he was young and did not have significant past medical history, I performed a diagnostic angiogram to rule out the presence of a vascular malformation or aneurysm. And his vessels looked very clean. He did not have any arterial cause that I could see of this hemorrhage. So we move forward with evacuation on the same operating table that we perform the diagnostic angiography. Here's the trajectory I chose. This is along the long axis of the blood clot as much as possible. It goes through non-eloquent brain region. And this way I'm minimizing torque on the surrounding brain and trying to get in there by causing as little injury as possible to the brain that must be traversed to get to the blood clot. Here's looking at the blood clot right when the sheath is placed. And now the aspiration wand is coming in. And you can see now activate it, aspirate out that blood clot. And now I can see there's some active bleeding coming from within the cavity. And the plan here is to continue irrigating, turn up the irrigation a little bit, continue washing the new blood, while also continuing to aspirate the old blood and make space within the cavity. Here it is after 20 minutes or so. And now you can see there's a little bit of space. There's still some active bleeding and still some residual blood clot. So I'll continue irrigating and continue washing and aspirating residual blood clot while looking for whatever's bleeding. Now I can see there is some active bleeding coming from this top area here. And you're going to see my cautery tool come in the top and cauterize that active bleeding vessel there. Here's the cavity when it's completely clean. And now I can confirm the fluid in the cavity is clear. It's not murky. There's definitely nothing bleeding. And what I'll do there is I'll turn off the irrigation and watch the cavity with no irrigation or flow to make sure that I can see that there's nothing active. And then I'll remove the device and I'll inspect the tract as I'm removing the device to make sure there's nothing active along the tract. Here's that gentleman's post-op day 1 CT. And we use artificial intelligence to quantify the residual blood. As you can see, and it said that there was less than or no intracerebral hemorrhage identified on that scan, but it's about 1 cc remaining hemorrhage there. And here's the gentleman on post-op day 4, and he was neurologically intact at that point. He left the hospital after coming down and speaking to a group who I was giving a presentation to. You can see he's still got his IVs in and he's still got his hospital bracelet, but he took those off shortly after and went home that day. And I think with that, I'll stop and take any questions. Thank you very much for the opportunity to speak. I see there are a few questions in the Q&A. And so I'll go through a few of those. How often did you have to change from endoscopic into open procedure because you were unable to achieve hemostasis? That's an excellent question. And that is the main challenge in setting up this procedure, is getting to the point where you're confident enough that you're not going to ever have to do that. The only time I ever had to do that was when I encountered an arteriovenous malformation that was it was negative on the CT angiogram, and the patient was elderly. So it was quite a surprise to encounter a malformation in a very large blood clot. And so what I had to do in that instance was obtain hemostasis within the endoscope. And then when I had hemostasis, then I transferred the patient to an operating room so that I could do a standard craniotomy and AVM resection. That wasn't because of uncontrolled bleeding in that particular case, but it was because of the pathology I encountered. I really needed more tools than I had in the angio suite to achieve that. But there has been no case in which I've not been able to obtain hemostasis. So I think that with the techniques I've described here, it really is possible to avoid a conversion to a craniectomy or a craniotomy. In my hospital, we do not have neuronavigation in the angio suite and not enough space to perform surgery in the angio suite. So we'd have to do it in the operating room. I think that is a completely reasonable solution. Many of my colleagues who I talk about this procedure with in real time work in the operating room. I think that just the thing to try to have is immediate post-op or intra-op imaging, so that if you're surprised by that imaging, you can go right back and do more work. So I would even call that an intraoperative CT. You really need to have the opportunity to have an intraoperative CT, even if you have to go to the CT with the probability of going back. I don't really, that's the main advantage of the angio suite in my perspective. Also in our hospital, we have a very strong stroke team, and the stroke team of nurses and technicians run the angio suite. And so it is a pleasure to work with them, and they do a great job. So I like having the procedures in there. And then the operating room team comes down, and that will be a nurse and an operating room technician as well. And so we've got both teams going in the angio suite when we do these procedures. So I feel like having teams that are available at all times is essential, but really the intraoperative imaging is key. So if you can get that done in the operating room, then that's just fine. Can you please tell us more about the indication for hematoma evacuation? Do you remove them all independently of volume and location, exclusively endoscopic, or in which case do you perform microsurgical removal? That's a great question. I do prefer to do all of the cases minimally invasive. And I do that over microsurgical because microsurgical was an element of stitch, and stitch was ultimately negative. And so I'm trying to work within the concept of that evidence exists, and it seems like it didn't work out for whatever reason. Now I'm focusing on this particular technique that is in trial in some institutions, and I think really is an answer in the most minimally invasive way we can get to this blood clot and take it out. The criteria that we use at Mount Sinai has evolved over time, but in modern day, it's a hematoma volume of 20 or greater. That gentleman I showed was 15. We were doing it down to 15 earlier, and we have had some success with that. But I think 20 is what is done in the trials in general. And so we've attempted to match the trials with now the minimum of 20, and NIH stroke scale of 6 or greater, and that's modeled after some trials as well. So the patient has to have some neurologic deficit with a supratentorial blood clot that is 20 milliliters or greater. And the patient has to not be significantly impaired at baseline. So a modified Rankin score of 0 to 3 at baseline. And the patient also has to have a CT angiogram that does not show an arteriovenous malformation. So having those are the major inclusion-exclusion criteria. And that's pretty much what we've been deploying, what we've been using over these years. What is the minimum prerequisite imaging workup do you recommend before considering evacuation, like CTA or DSA or tractography as an enrich? I think that CTA is an absolute must. I think that DSA for patients who are young and have no risk factors, and by young I mean less than 65, and they have no known hypertension or other risk factors for a hypertensive hemorrhage, even if the CTA is negative, but a CTA is mandatory. Regarding tractography, the approaches are fairly standardized, and so I'm essentially either going through, in 95% of the cases, the frontal lobe or the superior parietal area. So I'm using approaches that have been verified with tractography, but I'm not doing an MRI beforehand for every case. So I think it is possible to identify approaches and tracks that are unlikely to cause any damage from eloquent brain regions or tracks associated with eloquent brain regions by using standard approaches. And so I do not think that tractography is necessary, although it is nice to have. But when you're attempting to perform the procedure acutely, it might not always be possible to do an MRI and develop the DTI. Inserting the sheath, how deep do you go into the cavern and where do you place it? Inserting the sheath, I will generally do it 1 to 2 centimeters from the back wall of the hematoma, so that I can then work on that level and decompress, and then pull back a little bit and work at that level and decompress, and then work all the way back. With the endoscope, it's a little bit easier to work backwards than forwards when you're in the cavity. And so that's why I really like to do 1 to 2 centimeters from the back wall. You don't want to go all the way to the back wall because you don't want to start aspirating and see brain right away. You want to make sure there's a little bit of a buffer of the blood there. And then the final question is, when do you think is the optimal timing? Because ultra urgent surgery can induce rebleeding. Absolutely, that's absolutely right. There was a paper from 2001 showing that ultra early surgery could lead to a high rate of rebleeding, and that could be detrimental to the patient. Well, I think that early timing is better than late timing. And ultra early in that paper from 2001 was less than 4 hours. So I think the 0 to 4 hour window is a little bit of a black box. maybe bleeding is too challenging to handle in that period of time. But I think it's probably handleable with an endoscopic technique when you've got good visibility and you're able to use the advanced techniques that I showed. So I think that it's going to take some prospective studies to look at, is it safe with minimally invasive techniques within the 4-hour window? But I do think that the 4 to 12-hour window is a very nice window, and that's where I really like to perform a lot of the procedures in the 4 to 12-hour window. So to give you a straight answer on that one. And then the final question I see here, another one is hematoma stability mandatory? No, I really don't think so. I think that if you see a spot sign on the CTA or there's been expansion and you are confident in your own practice that you can handle intracavitary bleeding, as I am confident, then I think getting in there and mitigating the bleeding is helpful to that patient. And so it depends on your own confidence level in performing this procedure and your own experience in handling bleeding. But I do not think hematoma stability is mandatory. And in fact, I think that if you see a spot sign or expansion, that might even be an indication for you to get this done faster to try to prevent expansion, which we know can be deleterious to the patient's outcome. And with that, I think that's the final question.
All right. Well, thank you for the excellent presentation, Chris. And thank you to all the attendees. We will send out an email after the webinar with a recording, so you can have that for your records. And yeah, so thanks again, everyone, for another great webinar.
Thanks, everybody. Have a great day.
Have a great day. Bye-bye.